with our second lecture. For the first time, we're having Dr. Walid Shibl. We're honored to have him with us today. Dr. Walid is an ITU consultant at Qatif Central Hospital, KSA. He has a master's degree of internal medicine, Cairo University, Egypt. He is European diploma in intensive care and a specialty certificate in acute medicine, UK. He is today giving us a very up-to-date lecture and needed everywhere. It's the role of ultrasound in diagnosis and management of shock. Can we start, Dr. Will, can you unmute your, yes, please.
Okay, good afternoon, everybody. First of all, I need to thank all the organizing committee for giving me the opportunity to be with you today. We'll start by lecture. I have no disclosure. We'll start by rule of ultrasound in shock management. Our objective is value of ultrasound in diagnosing almost all cause of shock and the value of ultrasound in treatment of shock. Now, most of the international guidelines recommend the use of ultrasound in management of shock. This Survival Sepsis Campaign, European Society of Intensive Care Medicine, International Federation for Emergency Medicine. I know all of you know about this great rush protocol for management of the type of shock. As you see here, for management of obstructive causes of shock, the sensitivity reaching 100% with specificity 97. In case of cardiogenic shock, the final agreement with diagnosis of ultrasound with the final agreement with diagnosis is 89%. And with hypovolemic shock, it's going 86% agreement, 100% sensitivity. Distributive shock, 75%. Great number. You are talking about great number for all types of shock. Really, it is a must now in management of shock. There is a lot of protocol for use of point of care ultrasound in shock. Let us talk about our protocol. What you want first to know to diagnose the cause of shock. You are asked to see a shocked patient in the emergency department or medical ward. The first questions you need to ask, I believe, will be very important in shock, the volume status. If you see this, you will first target the inferior vena cava, which is the big vein, to give you an idea about the volume status of the patient. This is the first step you need to go through in the proper management of shock. If you see this type of inferior vena cava, which is narrow, totally collapsing in a shocked patient, you will think about distributive and hypovolemic cause of shock. But if you see this dilated, non-collapsing inferior vena cava, you will think about obstructive and cardiogenic cause of shock. So, by one image, you can get it in less than 1 minute. You can divide the cause of shock 50% and the 50%. Moreover, you can start your If your patient is shocked with this type of inferior vena cava, probably you can ask the nurse to start IV fluids bolus. If your patient is shocked with this type of inferior vena cava, you can ask your nurse to start inopressors. You can start the management in no time. Okay, let us go a step-by-step approach with your shocked patient. If narrow collapsing inferior vena cava, you think about hypovolemia and distributive shock. First, hypovolemia. Especially in trauma patient, you need to search for internal bleed in the abdominal chest. So, if the inferior vena cava is narrow and collapsing, you will search for internal bleed, especially for trauma patient. For the one who has no experience with ultrasound, you used to see 3 colors by ultrasound in the abdominal chest. The black anechoic color, which is going with free fluids, and the hyperechoic white color is going with bone, fat, and gases, and the hypo in between, the gray color, which is the organ. So you will do the fast exam for your patient to search for internal bleed in a specific area. First, subhepatic. Second, in Morrison pouch between the liver and the kidney. Third, around the spleen. This is the diaphragm, and this is the spleen, perisplenic, and splenorenal, and pelvis. Okay. Now you search for site of internal bleed in the abdomen. You should go to the chest to look for the pleural space. This is the diaphragm and the liver, and this is the blood, dirty fluids, turbid fluids in the pleural space. Okay. After finishing searching of extended fast for internal bleed, please go to the abdominal aorta to exclude abdominal aortic aneurysm. You see this aneurysm with dissecting and big clot here as a cause of hypovolemic shock. And I know most of you are running a surgical ICU. There is very important cause of hypovolemic shock you need to search about in post-operative patient, which is the ileus. You should look for the intestine, look for this loop of intestine, dilated loop of intestine with to and fro movement of the fluids, a lot of third spacing of these fluids. This is a common cause of surgical ICU because of third space and hypovolemia. Okay, now you finish the hypovolemic shock. Second, you need to look for the distributive shock, septic shock. The traditionally speaking, the common cause of septic shock in ICU is ventilator-acquired pneumonia, line-related sepsis, central line-related sepsis, urinary tract infection, intra-abdominal infection, and others. So you will look for ventilator-acquired pneumonia, very easy. As you see here, this is a normal lung. You used to see A lines, and if the lung became hepatized and consolidated, look for this is the spleen, this is the diaphragm, and this is the lung became hepatized. This is a ventilator-acquired pneumonia. Very easy, you can diagnose pneumonia by ultrasound, compare between the normal and this consolidated lung. Second, complication of pneumonia, you can get it by empyema, a lot of fibrin strand here in the pleural effusion, going with the complicated pneumonia empyema, and line-related infection, central line, is very important to exclude. As you see here, this is the internal jugular with thick wall and mobile thrombus here. You can get this image very easy and very quickly by high-frequency probe, and you can diagnose central line-related infection very easy. If you see this once, you will not forget. Third, the urinary tract infection. By applying the curvilinear probe in the bladder, very easy you can get this view of the dirty urine and the pus sedimented here as a cause of urinary tract infection. And if you see this image, probably you need to go to the kidney to look for bio-ureter and bio-nephrosis with dirty urine inside. If you, and this picture really is very clear, and if you see once, you will not forget. And I will give you a link to can do for all this. You can do it yourself very easy if you have the machine. Okay. Third, you need to exclude. I know you are running surgical ICU. There is a lot of intra-abdominal infection. You need to exclude in a shocked patient. You should look for peritonitis. This is a picture of peritonitis. A lot of fibrin strand and exudative effusion in the abdomen, and liver abscess. Very clearly to see liver abscess here. You see this is the diaphragm, this is the liver, this is the abscess, and there is a pleural reaction here because of inflammation in the liver with fibrin, and the inferior vena cava is collapsing here. You can get a lot in one shot really. And don't forget this famous acute cholecystitis with thick wall and the pericholecystic halo in this patient. This patient is sickler patient, and he really developed a very severe salmonella cholecystitis. It was only sensitive to meropenem, and despite taking the 2 weeks of full dose meropenem, she's still septic, and we search for the cause of persistent sepsis, and we find in this patient multiple hypoechoic area in the spleen, which is salmonella abscess in the spleen as a cause of sepsis. Okay, so narrow collapsing inferior vena cava, you think of hypovolemic, exclude by extended facet internal bleed, ileus and aneurysm, abdominal aortic aneurysm, and exclude the sepsis by looking for vitreoacquired pneumonia, line infection, urinary tract infection, intra-abdominal infection, and please don't forget, I like surgeon a lot, I respect surgeon a lot, but please, you are running a post-operative patient, don't forget last but not least, post-operative related sepsis. Please, by ultrasound, check yourself for the wound and for the internal collection. I respect the surgeon, but please check yourself. You see here, this patient with left upper thigh abscess with turbid fluid inside. He after aggressive debridement of the bed sores, really. This patient, he has undergone anterior approach cervical spine fixation, and after that you see a very bad collection here in the neck around the great vessels and thyroid as a cause of sepsis. And this patient has decompression craniectomy, and the patient remains septic and disturbed conscious level. And we did, by high frequency probe, we did scanning of the area of the surgery. We found fluids under the skin and below the muscles, and we found fibrin strand here and thickness of the meninges. And when we did CT with contrast, there was contrast enhanced to the meninges, and there is infected collection. We aspirate this, there is infection inside. So I respect the surgeon a lot, but please, in post-operative patient, try to check on the wound and the size of internal collection. Okay. Okay. Unfortunately, anaphylaxis is not diagnosed by ultrasound. What if the inferior vena cava is dilated? It's elephant inferior vena cava, dilated, non-collapsing. Probably you will think about obstructive and cardiogenic cause of shock. Let us talk about first cardiogenic cause of shock. When targeted cardiogenic cause of shock, you will first look for the muscles, generalized global hypokinesia, and the wall motion abnormality, and you will check the valves, and you will check for endocarditis. If this patient is shocked in the ER with this very bad, with very poor ejection fraction, probably cardiogenic shock should be considered in this patient. If this patient in the ER shocked with moving lateral wall, proper movement of the lateral wall, but no movement at all in the anterior and the septal wall, akinesia, probably you should think about myocardial infarction as a cause of shock. If this patient with dead right side, not moving right side, dilated with severe tricuspid regurg, this probably right ventricular infarction leading to shock. And don't forget this common scenario we used to see a lot in the ICU, the Takotsubo syndrome with hyperkinesia of the base of the heart and the akinesia of the apex of the heart. Is that Takotsubo with all type of stress at ICU, you expect to see this type of lesion, and it's very important to diagnose because it is reversible. This patient has status epilepticus, and after control of epilepsy, you see here the contraction regain normal, and this is really a reversible problem. So you need to, for cardiogenic causes, exclude the muscle disease. After that, valve disease, you need to exclude severe mitral regurg as a cause of shock. You need to exclude severe aortic regurg with dilated aorta as a cause of shock. And lastly, you need to check for infective endocarditis and look for any vegetation. Okay, this is as regard cardiogenic causes. What second, obstructive cause of shock. Really, obstructive cause of shock, you need to think of three common. The most common is pulmonary embolism. I saw 1,000 of cases of pulmonary embolism. But as regards the other two causes, which is the tension pneumothorax and the pericardial tamponade, it's really not so common. Let us start by pulmonary embolism, and I know you're running surgical ICU post-operative patient or orthopedic patient. There is too much DVT and pulmonary embolism. How to very shortly and very clearly approach the case with pulmonary embolism. This is a great figure of the 2019 guideline of acute pulmonary embolism in European Society of Cardiology. We'll try to dissect this figure. First, inferior vena cava will be dilated and non-collapsing. Second, you will see right side is dilated, compressing the left side. Okay, this is the first clue to the pulmonary embolism, because right ventricle is 60% and less the size of left ventricle. But if you see this right ventricle more than the left ventricle and compressing it, you should start to think about pulmonary embolism. You see this patient, ballooning of right side, compressing left side. Okay, if you did parasternal short axis view, you will see the common D-shaped, left ventricle, D-shaped left ventricle, because of ballooning of the right side, compressing the septal wall. Okay, you will inform me, Walid, I know a lot of patients with COPD and the chronic lung disease, they have ballooning right side, compressing left side. How can I diagnose pulmonary embolism in this situation? Okay, it's very important. First, you need to look for dilated right side, compressing left side, and after that, you need to differentiate between acute and chronic core pulmonary. Right ventricle has thin wall, 0.5 centimeter. So right ventricle cannot tolerate pressure overload. If the thrombus obstruct main branch of the pulmonary artery, right ventricle cannot tolerate this resistance and it will fail. The right ventricle will fail and you will look for signs of right ventricular failure, acute failure. And at the same time, in acute pulmonary embolism, right ventricle has no time to compensate for this stress by increasing the thickness of the wall. So you will look for thin wall right ventricle and the acute right ventricular failure. Okay, let us see. This patient has chronic core pulmonale, has time to compensate by increasing the thickness of the right ventricle, but this patient has very thin wall because has no time to compensate. Okay. What about acute right ventricular failure? Right ventricular contraction is up and down movement, up and down movement. It's not squeezing mainly like left side. Look for this patient. Look for this patient with acute pulmonary embolism. Look for up and down movement of the right ventricle by looking for the tricuspid annular plan excursion here, and look for this patient with chronic core pulmonale moving very well with thick bulky wall. This is chronic process. Right ventricle is compensated, but this is acute process. We can objectively measure this up and down movement, but by what's called the TAPSI, by moving by M-mode here, as you see, we can put M-mode cursor here and measure this up and down movement. In this patient, it is 1.1. It's very low. In this chronic patient, it's 2.4. So it is this in pulmonary embolism, you will see low TAPSI and the thin wall. If dilated right side, compressing left side, go to look for the wall of the right ventricle. If the wall of the ventricle is thin, not thick, and the TAPSI is very poor, you think about acute core pulmonale and pulmonary embolism. And you can check this famous McConnell signs, which is very specific for pulmonary embolism, but unfortunately not sensitive. You see hyperactive apex compared to the lateral wall akinesia. It's very specific for pulmonary embolism. You can see an embolus in the right atrium as this patient, and you can track this embolus. Second scan, embolus went to the lung, and the end result will be dilated, acutely dilated right side, compressing the left side. If you suspect pulmonary embolism, please go to lower extremities vein and look for the DVT. Here is the right common femoral vein with thrombus inside. As you see, when I try to compress the vein, it is not compressible because the thrombus inside. And if you fire the color, you find no color because there is thrombus all around it. Okay. Pericardial tamponade. The first pulmonary embolism as a obstructive shock, pericardial tamponade. Three things you need to look for: hypoanechoic fluids around the heart, and look for signs of tamponade, which is you see systolic collapse of the right atrium. Systolic collapse of the right atrium, you see with systole, there is invagination of the wall of the right atrium. And diastolic collapse of the right ventricle. Okay, systolic collapse of the right atrium and diastolic collapse of the right ventricle. You can track this collapse by, if you did M mode here, you can see the collapse very clearly here. During diastole, you see the right ventricle wall compressed here. Very easy, you can get it by M mode. Okay. To differentiate between cardiogenic and obstructive cause of shock, remember, pulmonary embolism, there is obstruction in the flow of the pulmonary blood. That means the blood going to the lung is low. There is low flow to the blood going to the lung. So in pulmonary embolism, you expect to see the lung oligemic, not well flooded by fluids like pulmonary edema in cardiogenic shock. So if you look to the lung, here, you will see in obstructive shock like pulmonary embolism, you will see a lot of air line, dry lung. But in cardiogenic pulmonary edema, cardiogenic shock, if the cardiogenic shock lead to this type of shock, it should lead to left atrial pressure increase and a lot of the fluid in the lung because of cardiogenic pulmonary edema. So dry lung going with obstructive shock and wet lung going with cardiogenic shock. Please, now you are in the chest, you need to exclude now the last cause of obstructive shock by looking for the pneumothorax. And there is very specific sign, which is lung point, very specific sign for almost 100% specific for pneumothorax. You will see one side of the pleura is not sliding, is dead, and the other side is sliding. This is the lung point, which is almost 100% specific for pneumothorax. And if you fire the M mode, you can see here the famous seashore appearance, alternate with barcode, which is the pneumothorax here, and area of lung aerated here. Okay, to sum up what we have just said, first thing to do for assessment of shock, check inferior vena cava, narrow, collapsing, go to do fast to exclude internal bleed, look for alias and abdominal aortic aneurysm. If the inferior vena cava is dilated, non-collapsing, exclude cardiogenic cause of shock. Look for global hypokinesia, regional wall motion, mitral regurg, aortic regurg, and infective endocarditis, and Takotsubo. And obstructive cause of shock, pulmonary embolism, dilated right side, dilated compressing left side, but thin wall with low TAPSE and pericardial tamponade, anechoic fluids around the heart with systolic collapse of the right atrium and diastolic collapse of right ventricle, and pneumothorax, don't forget lung pulse. Okay, as you see, we saw the value of ultrasound in diagnosing almost all cause of shock. In our protocol, it's not only type of shock, but also we go deep to know the cause of shock, not only the type of shock. What about the main treatment of shock? The main treatment of any shock is the proper IV fluids, proper inotrope or inopressors or inodilators, and the treatment of the cause. This is the proper treatment of any shock. Proper IV fluids, you need to give proper timing and the proper amount. What about proper timing? If you see, as we said, if you see this type of inferior vena cava in the emergency room with patient shock, you can ask the nurse to start fluid policies. So you start the management in zero time, in very appropriate time, okay? And as we said, ultrasound is great in selecting proper inopressor, because if you know the type of shock, you can select an inopressor. If the patient is cardiogenic, you can add on dobutamine. If the patient is obstructive shock, you will add noradrenaline. If septic shock, you will add noradrenaline. By knowing the type of shock, you can know the proper inopressor. And by knowing the cause of that shock, as we said, you can do the proper management. Suppose pulmonary embolism leading to shock, you can start thrombolysis. Septic shock, you can start antibiotic. You can start your management septic shock. Okay. Ultrasound is great in proper timing of IV fluids, in selection of inopressors, and in treatment of the cause. What's the remaining? The remaining is the dose of IV fluids, and I believe this is the most important, tricky questions at ICU, and the difficult question. And every day we learn from this tricky maneuver, which is the proper IV fluids for the patient in shock. Okay, let us see. I was asked to assess a 75-year-old male patient admitted 2 days back because of acute cardiopulmonary edema due to severe ischemic heart disease, ischemic cardiomyopathy precipitated by chest infection. Common scenario, ischemic myopathy with pneumonia. Over the next day, with proper anti-ischemic, anti-failure antibiotics, the patient doing well, improved ventilation, FiO2 requirement from 100 to 40%, all chemistry improved apart from creatinine, which jumped from 2.6 to 4.4. Patient develops severe hypotension, blood pressure, and the lowest value 50/30, heart rate 100. Patient already on tubutamine 115 mg per kg per minute, noradrenaline 20 mg per minute. This is the X-ray on admission, and this is the X-ray after improvement. Let us talk ultrasonography. You have now patient with renal impairment and ischemic cardiomyopathy with infection, and is hypotension now. We'll start to assess the patient. We did first inferior vena cava, but because the patient on mechanical ventilation, we are not looking for the inferior vena cava collapsibility, but we are looking for distensibility, because patient with mechanical ventilation, the inferior vena cava will dilate, will increase in size with inspiration and decrease with expiration. So look for distensibility, which is a maximum diameter during inspiration minus the minimum diameter over the minimal diameter. The cutoff point is 18%. For this patient is 34%. That means the patient is fluid responsive despite heart failure. You see here, ejection fraction is almost 10%. We did sensor methods, it was 21% ejection fraction. Okay, now it's very important questions now. You have patient with ejection fraction of 10%. You have patient with ejection fraction of 10%, non-ischemic cardiomyopathy, and he is hypotensive. To give fluid or not to give fluid? Number one, inferior vena cava is denoting fluid responsive state. But this great American Society of Echocardiography and European Association of Cardiovascular Imaging guideline in 2016 about diastolic dysfunction said a very important guidelines here. If your patient has heart failure, with ejection fraction 10%, put the pulsed wave Doppler at the tip of mitral valve and look for the mitral valve inflow, E over A ratio. E, which is the passive feeling of the left ventricle, and A, which is the atrial kick. Okay. If the E over A ratio is more than or equal to with patient with severe heart failure, that means there is increased left atrial pressure and the grade 3 diastolic dysfunction, and your patient need to be deloaded. You need to remove fluids from your patient. If the E over A prime is less than 0.8 with E less than 50 centimeter per second, look, it is normal left atrial pressure with diastolic grade 1 diastolic dysfunction, and this patient may need fluids. Our patient, the E over A prime was 0.6 and E velocity 37. That means it's grade 1 diastolic dysfunction with normal left atrial pressure. Okay, the lung is dry. All the lung was A-line, and the kidney was a small chronic kidney. To sum up, to fit the puzzle together, bedside ultrasound was done, revealed bad ejection fraction 10%, grade 1 diastolic dysfunction and normal left atrial pressure, very small right ventricle, inferior vena cava distensibility 34%, dry lung, small kidney. In this patient, despite low ejection fraction and the chronic kidney disease, you can give fluid challenge and check. Okay, fine. What's next? You will give fluids, but how much fluids you are giving? Let us see. We need to rely on the dynamic variable in fluid responsive state. As all of you know, this is the famous Frank-Starling curve. This is the stroke volume, and this is the preload. Preload is the fluid I will give to the patient. And what I expect from the fluid I give to the patient is the increased stroke volume. But there is multiple Frank-Starling curve. But our patient, because of severe heart failure, he is on this curve. Okay, not this curve. So I can give fluids as long as stroke volume is increasing here. Okay, but in this plateau, giving fluids will not increase the stroke volume and will worsen the congestion. If I start to give more fluids in this area, if start to give more fluids in this area, I will get low stroke volume because of distension of left ventricle, and at the same time, too much and too bad systemic congestion. Okay, so I need to give fluids as long as the stroke volume is increasing. So I am in the right track. It's very clear. Okay, what can I know the stroke volume by ultrasound? Yes, very easy. If you put the pulsed wave Doppler here, this is a 5-chamber view. I will put the pulsed wave in the outflow tract of the aorta here. I will get this Doppler flow. If I trace this Doppler flow, it's called velocity time integral, and I can get the value of tracing, and this you can consider it is the surrogate of stroke volume. This is a surrogate of stroke volume. Now, in our patient, when we did the blood pressure invasive was 63/50 and in mean 57 with fluctuation of pulse pressure here, of course, hypovolemia. I did this trace of the VTI and it was 6.3. That means normal from 18 to 22. That means this patient has very low stroke volume. Very low stroke volume. This was at 7:30 o'clock. Okay. I give 100 human album 5% BBF and I check again the VTI, it reached 8.55 and the blood pressure start to increase. This happened after a couple of minutes, okay? I give another 150 BBF. You see the stroke volume here increase to 12.17 and the blood pressure reached 110/70 and no more fluctuation of pulse pressure because of improved hypovolemia. So, and this happened after 30 minutes. So, by ultrasound, we know by inferior vena cava that this patient is fluid responsive, and by grade 1 diastolic dysfunction and the normal left atrial pressure and the dry lung, this patient is safe to give fluid and he needs fluid. And I started to give fluids and follow up the stroke volume. As long as the stroke volume is increasing, I'm in the right track. As you see here, this is the dynamic way how to give the appropriate amount of fluids and need frequent assessment to the patient. Inferior vena cava started to get up, and there is a lot of reference really about that. And I believe now, after this full meal of how to approach by diagnosis and the treatment, is it the time of our protocol? Our protocol differs than other protocol because it tackle not only the diagnosis of type of shock, but the cause of shock. We go beyond and tackle the cause of shock, and we can start the management very early. As I said to you, you can start at the time 0 in the patient. Is it the time for protocol? You are ready for protocol? This is the habit of Dr. Hussam Abdelrazik, famous consultant in emergency in Riyadh, and this is my cup of tea, unfortunately. Okay. Right. This is the REMS protocol, not rush protocol. Okay. First, look for the inferior vena cava. If narrow and collapsing, consider hypovolemic and distributive shock, and search for internal bleed, abdominal aortic aneurysm, ileus, and the source of sepsis, VAB, line related infection, urinary tract infection, abdominal infection, and the famous post-operative related infection. If inferior vena cava is dilated and non-collapsing, look at the heart for cardiogenic and obstructive cause of shock. If suspicion of pulmonary embolism, look for DVT. Step 4, look at the lung for lung water to differentiate between cardiogenic and obstructive. In cardiogenic, wet lung, pulmonary edema. In obstructive, dry lung, ALI. And don't forget to look for lung pulse of tension pneumothorax and to guide IV fluids by new appearance of P-line of IV fluids. Step 5, follow up proper IV fluids by assessing the solid function, LVOT, VTI, IVC, and lung water. And step 6 will come to ultrasound club. I know you will be, I hope all of you will be like this rabbit. And this is the link of channel, my channel in YouTube. You will find a live video how to assess very simply the inferior vena cava on volunteer live, how to do LVOT, VTI very simply, how to look for the kidney, how to, it is almost 50 or 60 live video. And you will find one playlist we apply this protocol for more than 100 patients. Playlist for only for shock. We apply this protocol hundreds of times, and you will find hundreds of shocked patients. This protocol work very good for the patient, and I believe will be very helpful. I know maybe some of you has no experience with ultrasound, but believe me, invest in ultrasound. You will get a lot from ultrasound. And now there is a lot of courses, and but it's the most important thing, the machine should be available. And thank you for appreciated listening. And I'm happy to listen for any questions. Thank you.
Thank you very much, Dr. Walid. We don't have many questions. I think, thankfully, to your illustrative, I myself really like the illustrations very much. And I want to pass the thanks of many of the attendees. They have been sending thank you for the lecture. Thank you very much. We don't have many answers and many questions, one of which is that if you can, in a nutshell, give us more details about diastolic dysfunction in ultrasound, just like to make it as simple as possible.
Diastolic dysfunction, I will make the long story short. Yes. Diastolic dysfunction, you need to apply in patient with cardiac disease, okay? In patient with cardiac disease. In patient with cardiac disease, especially patient with heart failure, to give fluids or not to give fluids. This is the most important questions, okay? So, in patient with heart failure, what are you going to do? Only to put the pulsed wave Doppler at the tip of mitral valve. It's very easy, and I have a live video how to do it. It's very easy, and you will get the E wave and A wave. E wave, which is the diastolic feeling, passive feeling of left ventricle, and the atrial kick of the A wave. If the E wave over A wave more than 2, that means your patient with low ejection fraction has increased left atrial pressure. Take care. But patient, especially if you need to wean the patient from mechanical ventilation, please give Lasix, because this patient can drown in pulmonary edema. This patient need deloading. But the other thing, this is third of cases. The other third is the E wave, E over A is less than 0.8. It is the reverse is happened. The E wave is not high velocity, it's low velocity. It's less than 50 centimeter per second, and E over A is less than 0.8. In this situation, don't worry. Even if your patient has heart failure, your patient has low or normal left atrial pressure, and you can give challenge of IV fluids guided by lung water. Very, very safe. Don't worry, very safe. And believe me, the most common, I mean this, the most common of shock in CCU is hypovolemic shock, because they are keen to give diuretics. They are great in giving diuretics. All patients I saw in CCU, they are hypovolemic. They need fluid challenge, even if the ejection fraction is low. But you should be targeted. Give fluids and look for stroke volume. If increasing, you are in the right track. And look for the lung. If lung is A-line, you are safe. You are safe, because starting the B-line in present, and if the area is A-line and start to get B-line, that means you need to take care and you stop. Okay, it's very, very important and very safe to give fluids for cardiac patient in this situation. Okay, this at the moment, the best way of fluids, which is the fluid to increase stroke volume. But for me, the future, the thing will change. We are going to look for microcirculation for the microcirculation of the vital organ. But at the moment, this is the evidence base. This is the best way to give IV fluids.
Okay. Thank you.
There is in between very tricky point. Yani for non-cardiologists will be difficult. But let us talk about simply more than 2, give Lasix, less than 0.8, you can give fluids. Make it simple.
Yes. Thank you very much, Dr. Walid. No enough thanks are covered this illustrative, very informative lecture. It's like you're giving like an eye inside the patient. I think the ultrasound inside the patient. Thank you very much.